we're doing advanced EMT and EMT together in one class. I love doing this. If you guys have any questions, please put them in the chat for us. That way we can see and we can keep a record of. So, this is just kind of that preemptive stuff. We're going to apply our fundamental knowledge and we're going to go through our A&P. We're going to look really in depth on our seizures, strokes, and our TIAs, along with epilepsy, status epilepticus, and headaches, okay? So just to get some stats out of the way, we have 2 of the top 10 causes of death in the U.S. are neurologic. Remember, the number 1 killer is stress, okay? But stroke is the 5th leading cause of death in the United States after heart disease and cancer. So this is a big deal. Understanding neuro is huge. You will run a lot of neurological issues in your career. So seizures can happen for a number of reasons. And so recent or old head injuries. You may have a person that was in an accident. They had a fall or in a motor vehicle accident, and they were okay. Maybe they weren't great, maybe they were okay. And then a year later, they can develop seizures from a brain injury or a TIA, a TBI, a traumatic brain injury. Brain tumor. Okay, that's as organic as it comes, guys. That can press on certain areas of the brain and cause that activity. Metabolic problems. That's like if you're sugar. Diabetics can have seizures. I've seen that a couple of times. Other ones, which we'll get into in just a little bit, but there are, and I'm trying to pull back from being a paramedic and a nurse here so that I don't get so far in depth. And then genetic predispositions, and that's also going to be like your epilepsy and things of that nature, okay? So let's talk about just what altered mental status is real quick. That's super common, and that's literally when they don't know the answers to those 4 questions, okay? Remember, you have your GCS score that's 15, and that's wonderful, but that's not necessarily what we're talking about at altered mentation. We're talking about, and AVPU, if they're alert, okay, we got alert, but are they oriented? Are they oriented to person, place, time, and event? Okay, so if they can't answer those 4 questions, we have an altered mentation. If they are only responsive to verbal stimuli, altered mentation. If they are only responsive to painful stimuli, altered mentation. So, and there's a wide range of reasons that they can have that altered mentation too, obviously. So one of the big things about our neuro patients is they are extremely vulnerable and even helpless at times. So we have to really take care of those people. We'll talk about seizures in just a minute and what happens there. So let's talk about just A&P real quick. Now, I can't see that diagram very well because it's really, really small on my computer screen. But the nervous system it's a computer. It's the computer of the body, okay? And it has this neural network that comes from the brain, goes down through the spinal cord, and then it offshoots and all these nerves that communicate, and they go all the way to our fingertips and everything else. And think about this. If you heard, I'm sure you guys have heard of knee-jerk reaction before. So you drop something on your foot, and I cringe thinking about it, okay? You drop something heavy on your toe. Ugh, hurts. But it takes a second. Like you've already, man, this is going to hurt so bad. And pain hits. So that's how long it takes for that painful stimulus to run up the brain and saying, hey, I think we have a painful stimuli here. And the brain said, yep, that's exactly what that is. And it sent another thing down saying, yep, you sure did. It's painful. And then you go, ow. Okay, so that's the neural pathway that you're feeling, okay? And it's responsible for fundamental functions. One of those is going to be like your breathing control. It's going to be your heart rate, your blood pressure, temperature. It also responsible for your higher level functioning, such as memory, understanding things, how we communicate, how we even think, okay? So when I say it is the computer of the body, I literally mean this. And of course, we have their 2 major structures, and that's going to be the central nervous system, which obviously the central, and then your peripheral, which is going to be outside of the central, okay? All right, so the brain. Y'all can read this. If we didn't have a brain, we couldn't do anything, okay? You have a brainstem, cerebellum, and cerebrum. The cerebrum is the largest part, and the brainstem controls our most basic functions. So when the brainstem is the one that's really in control of the body. It deals with your breathing, blood pressure, the ability to swallow, and pupil constriction. And so if you see where the brainstem is and understand that if you have damage to, let's say, the frontal portion of the brain, that it may not affect the brainstem. And I bring that up because I want to talk about, even though we're not in trauma right now, I do want to talk about that there are traumatic injuries that take place. Gunshot victims, whether suicide or not, if they get shot in the head, or they have major brain injury, skull, whole 9 yards, and it's just the frontal portion. And we all know there's no way that this person is going to live due to the amount of brain loss that we can see. Sometimes these people are still breathing. They still have a heart rate. Their pupils may even constrict because that brainstem is intact. So I want you to understand how powerful our brain is and the communication that happens. So the cerebellum controls muscle and body coordination, and it is divided into the right and left hemispheres. Remember, is the big one, okay? The cerebrum is right here on both sides, right? So the front, that's going to control your emotions and thoughts. So if someone has been hit in the head in the front really, really hard, they have a bad injury, they may change who they are. And we talked about that for like a split second with a TBI, traumatic brain injury. And if they have a stroke right here, they may even have problems processing emotions, or they may change their emotional behavior and even their thought patterns. And the middle is going to control your touch and movement, and then your back is going to process the sight. So if you have somebody that gets hit in the head really hard, then they may black out as far as like their sight is concerned. That's something that I've seen before in the field. Most people, the left side right here of the brain is going to involve speech, and the middle part, like I said, is going to be the touch and movement. So if you have strokes in various areas of the brain, that's going to really handle specific things that we're capable of doing. So the brain sends these messages to and from, and it travels through our nerves. We have 12 cranial nerves. I'm not going to make you guys know those. Go to paramedic school or nursing school. You will need to know those. You are going to rest of the nerves join in the spinal cord and exit the brain through the foramen magnum. Okay, so we've talked about the foramen magnum before, and how that has an issue if it goes through the brainstem goes through the foramen magnum. Okay, so if you've never heard of dermatomes, this is the coolest thing in the world. Okay, like legit cool. At each vertebrae, in the neck and the back, there are 2 nerves that do branch out. These are called our spinal nerves, but they carry these signals from the brain through the spinal cord to the rest of the body, right? So we have to have that coaxial cable, if you will. Okay, maybe I'm saying it the wrong way, I don't know, but it's a cable, right? The areas of the skin and sensations correspond to specific nerves, spinal nerves, and these are called dermatomes. Guys, if you break, I want you guys to really look at this slide. I want you to find this in your book. I want you to look at this. And I can't see this, not really, but I can tell you, tell me where you think the diaphragm is. What dermatome is related to that particular area of the body? You tell me where that is. And if you are driving, please don't try to look this up. You don't have to put in the chat, okay? But if you're not driving, I would love to know. Which one, okay? I can't see. I think it's higher than that, but okay. I thought it was higher.
Sorry, Patricia, I'm here now.
Okay, thank you. Okay. Yeah, it's going to be up in there. It's going to be T6, T7, T8. If you have a spinal cord injury in that area, what happens is you have a break in communication from that point below. What happens when you break communication? Nothing works below that area. So if you have someone who breaks their spinal column, they break their spinal cord, let's say it severs, then they will stop breathing. They will stop breathing. So this is why it's so important for us to understand dermatomes. You look at this and you're like, what in the heck is that? And I didn't even tell you about the homunculus. And if you want to know about the homunculus, go look it up. That's a real thing. That's what we were when we were in the womb. But anyway, whatever. I'm digressing here. Okay. All right. And it's totally fine. It's a higher, I'm pretty sure it's higher than that, but it's been a minute since I've looked over it. Hold on, Mark. I'm missing this.
You good? Don't worry about us.
Okay. I'm trying to figure it out. Okay. Okay. So, when we think about where these dermatomes go, if you look at the hands, so now we know what a dermatome means. It means that we have communication from the C1 through C7, T1. I mean, and it continues to go. Okay, I'm not going to continue going down the spinal column, but that's what a dermatome is important for. And you probably will see that on a test in the future. Okay. Okay, so neurons and impulse transmission. Now, this is the coolest thing in the world. Remember when we talked about cardiac cells and how cardiac cells were made in a specific fashion? Well, neurons, they are our nerve cells, and they are the same way. They also carry an impulse, and this impulse is full of information. And so they're composed of 3 basic body parts. That's the cell body, the axon, and the dendrites, okay? And if any of those are not working and not communicating, then nothing happens. And I can go into an hour-long spiel about how the cell body, axon, and dendrites work together. I will save you from that lecture because you're not in the paramedic class. But if you go, it's really interesting. Like, I get really excited when I talk about AMP. Anyway, but you have so let's say we have a neuron here and a neuron here, and we need to get information from this neuron to this neuron. So what do? We have a synapse. And if you can't have the synapse, then this information is not going to get from here to here. And it's actually more like this because the dendrites kind of touch each other, There's like a little bit of an area in between, and the synapse that impulse will jump from one dendrite to the other, moving up the axon to the cell body and then moving and continuing on, okay? So most neurons are actually neurotransmitters, and they are going to help transmit all that information across. So your cell body is going to, I'll have to pop out at some point before class is over. We'll finish recorded lecture. Thank you, Kristen. I appreciate it if you'll just send me a little bitty email saying that. That way I have that down. Okay, so your cell body is going to have your nucleus because it's kind of the whole point of that one. The axon has like the projections. And so that's why I was like, oh, they communicate like this because it's kind of like fingers. And they just kind of extend towards each other to carry that signal. And then axons may or may not be wrapped in a sheath of myelin. And the reason they have the myelin sheath is to help with insulation of that. They want the ones that are wrapped in myelin are the ones that carry a synapse better and quicker, okay? What else can I say about this? Ma'am? Oh, please mute.
I did. I'm sorry. That was my radio. I just walked in the door from working.
Okay,
So
thanks.
I'm sorry. I didn't. Oh, gosh.
It's all right.
All right.
I can mute you.
Everything's gone off. I'm sorry.
It's all
Can I ask you what page are we? I mean, I know we're on chapter 18, but is this in the advanced class or the regular chapter?
We're all together tonight, so this is going to be advanced.
Okay, so what page are we on?
I have no idea. We are
Okay.
on slide 14 is all I can tell you.
Slide 14.
We're on
Okay.
neurons and impulse transmission. If somebody can drop in the chat what page you guys are on to help, because I really don't know. Okay, I'm gonna go ahead and mute, that way we can continue,
All
okay?
right, I'll mute it.
All right, great. Okay, so neurotransmitters are going to take that electrically conducted signal from one neuron, and they're just going to relay it to the next cell, and then they're going to continue to fire. But hey, sometimes they don't fire off, right? So as you can see here, those axons, they stretch out like finger-like projections almost, and they will continue to stretch until they get where they need to go, and then they'll jump with that neurotransmitter, and that's kind of like that in-between portion. It's like, hey, I'm here, but I need a little something to get over that that synaptic cleft, which I'm not gonna, let me stop because I'm getting a little too far into that. Okay, so there are many different disorders that may cause neurological symptoms and affect the patient's level of consciousness, speech, and voluntary muscle control. Oh, we're on page 995. Thank you so much, Mark and Christopher. Other brain disorders are going to include our infections, our tumors even, and those can absolutely cause seizures. They can cause augmentation and, of course, headaches. Because remember, if there's any kind of blood flow that's going to be an issue there, then yeah, there's going to be a potential coma. There could be a potential headache there. And remember, if there's any type of problem with the blood going to the brain, first thing that you're going to see is anxiety. They're going to be anxious. They're going to be restless. And there's going to be some confusion because the brain can only work on two things, or has to have these two things to work, I should say. And that is glucose and oxygen, right? Okay. So let's go into stroke. This one's big. So a stroke, by definition, is a cerebrovascular accident, a CVA, and it's an interruption of blood flow to the brain that results in the loss of brain function. So remember, if we have, okay, not sure about the basic book. Okay, and that's fine. It's probably somewhere right around that same area. But thank you so much. Let's see.
I found it, thanks.
Okay, you're welcome. All right, so 727. Okay, thank you. I appreciate that. Okay, let's see. Do not delay your response to a patient with a potential stroke, because the longer the stroke continues, then the less likely that patient will have a promising outcome. And I want you to write down in your book, highlight it, underline it, wherever it is, time equals brain. So if you have a patient who has an onset of symptoms and they call 911, we're talking within 10 minutes, you get there and it takes you 10 minutes to get there. We're in 20 minutes. We have 40 minutes to make it to a hospital that can give them medication to stop this, okay? And you can call a helicopter. Helicopters have this medication. Some ground transport units may have this medication. But for the most part, for the EMT and the advanced EMT, you need to understand that we need to get them to the ER as fast and as safely as possible, because time equals brain. Now, there are places that they can still give this medication within a 24-hour period. Others are 16, some are 8 hours. It depends on the hospital itself. But suffice to say, 1 hour of the onset of symptoms is a dead ringer of we can give them some medications that are going to help resolve all of this. But you have to keep in mind that when you have an infarct, you have something stopping the blood flow to whatever area of the brain, that all those brain cells are going to cease to function. They're going to die. It's just like the heart. You have irreversible brain damage within the first 5 minutes of a person being dead, because there's the lack of oxygen to the brain itself. So this is no different. It's just in the form of a stroke. But dead cells are considered infarcted cells, so definitely understand that. And remember, if a small amount of blood is still able to reach that affected area of the brain, it can actually supply just enough to keep that larger group of brain cells oxygenated, but they're actually ischemic at that point because they lack enough oxygen, but they do have some. Okay, so interruption of cerebral blood flow may result from a thrombus or an arterial rupture or cerebral embolism. And so clots are going to come in and develop locally. Then you have your arterial rupture, and that's one of course, your cerebral artery is going to rupture. And then your embolism, and that's just an obstruction of the cerebral blood flow because of a clot that was formed elsewhere, detached, and then traveled to the brain. So the difference between a thrombus and an embolism are two things. A thrombus is something that has built up over time, stays there. Whereas an embolism travels. And I like to think of it as an embolism embarks on another area, okay? Embolism embarks, okay? I hope that helps y'all. I like to keep it, I have that, hold on just a second. Someone's having issues getting in, and I keep getting, let me make sure they're in first before I continue on, you guys. I don't think they're in. Okay. They may try to get back in again in just a minute. Okay, so sorry about that, you guys. But I like to, the keep it simply sweet method. And if I can put two E's together, I'm gonna do it. So embolisms embark. They move from one area to another. And it may be in the form of like a, if you have a clot in your calf muscle, that breaks off, that's called a DVT, a deep vein thrombosis. And it stays there because it's a thrombosis, a thrombus, if you will. But when it breaks off, it can become a pulmonary embolism. It can become a cerebral embolism. So what does that mean? It just puts the area in front of the fact that there's a clot that's moving, okay? And I hope this helps you guys remember as you go through. Now, an ischemic stroke is where the blood vessel is blocked. So the tissue distal on the other end becomes ischemic, lack of oxygen, okay? Now, you do have atherosclerosis because guess what? We have blood vessels in our brain. So if you're continuing eating these, we're not going to talk about it. We're not going to talk about it, but we're going to talk about it. The McDonald's, stop it. I already know y'all are starting to type. The McDonald's and the Burger King and the secret menus and all the other, okay? Jared, stop. But you have atherosclerosis throughout your body, right? So it's not just like in your heart, it's going to be in your brain too. So you can have that atherosclerosis, that buildup of fat and bad stuff in your blood vessels. And that's going to put those plaques in the walls of your blood vessels. And so instead of having the ability to dilate, it's not going to have that at all. Jared and Lewis, y'all are being bad. I love it. Okay, loss of movement on the opposite side of the body is going to create the confusion, okay? It's going to create the inability to speak. It's going to create the inability to move. And so if you have a clot over here on this side, on the right side of the brain, it's going to be over here, okay? Okay, send Jared your phone number. He can tell you. Mark, y'all are terrible tonight. Okay, cerebral embolism could block your blood flow along with it. So we don't want to do that, right? That's really bad. And sometimes they are big enough to block complete blood flow. So it's not just going to be ischemic, then it's going to be dead tissue. So parts of the brain are supplied by the artery will become ischemic, also dead later on. I just want to make sure I'm reading all of these down. And so they may have anything from like just a very small amount of something that could be just tingling to they have complete paralysis and they can't move at all. And those are the ones that are really scary, especially for the patient, because the patient knows there's something wrong. They can't do anything about it. Now, hemorrhagic stroke, Okay, so clot is one thing, right? But hemorrhagic means that there's actual bleeding. That is terrible, Jared. I want to go to McDonald's now. You gotta stop. Okay, results from bleeding inside the brain. This is usually just when the blood vessel ruptures. You can have a hemorrhagic stroke for other reasons. And not for other reasons, I'm sorry. You can have bleeding inside of the brain other than hemorrhagic stroke. Let me pull back. I'm looking at this burger over here. It's killing me, you guys. I apologize. Okay. So the severity is just going to depend on the location, but also the size of the rupture. So as that bleeding continues, our ICP, remember our intracranial pressure, it's going to increase. It's going to compress our brain tissue. And when the brain tissue is compressed, oxygenated blood isn't going to get into the area. The cells are going to continue to die. It's going to continue to get worse. And then you're going to have on top of it, the brain is going to move down to the foramen magnum. So you're having a whole slew of issues at this point. So who are the ones that are at the most, are at the highest risk? Those are going to be the ones that are poorly controlled hypertensive patients. So they've had hypertension for years and they're like, nah, it's fine. It's just 170 systolic. I'll be fine. What do you mean you'll be fine at 170 systolic? Are you, what? This is cuckoo bananas. Stop it. We need medication for you. No, it usually runs that high. What? And I guarantee there's 2 of you on this call that have heard that exact same thing when you've been on a scene. So is that bad? Absolutely. I'll take that. I'm done with y'all. The Mona Lisa of fast food. I'm done. I cannot, y'all. I have to eat after this. I swear I'm going to come to school eating before I come deal with y'all again. Okay. So if you think about this, all right, get off of food, guys. We got to concentrate. We're in neuro. Ready? Okay. So if you have a tube, we're going to call it a blood vessel, and it has been under this super high pressure for years. Okay. I'm not talking about like a week. I'm talking about years. There are going to be portions of that blood vessel that become weak because of the high pressure, the amount of high pressure that is involved in that blood vessel, right? So when that happens, when that little bitty weakened area happens and that blood pressure goes up one more time, it's going to break. It's going to be more prone to that rupture. So when you have that, we're going to have our stroke, our hemorrhagic stroke, okay? I will say that cerebral hemorrhages are often fatal. Proper treatment of the hypertension can prevent long-term damage, but for the most part, it is, in some cases, too little too late. People who are born with a weakness in one or more of the layers are also associated with an increased risk for hemorrhagic stroke. And aneurysms can occur in 2 different ways. I'm sorry, 3 different ways. Let me read the rest of this. Okay, you can have that small tear or defect. Blood penetrates between the layers of an artery. That can definitely happen. And then pressure buildup, and the initial small tear increases in size. So when you have a tear already, and let's just say your blood pressure is like 150 systolic, but then your blood pressure goes up to 200, obviously you're putting more pressure into that system, and it's just going to continue to move out, okay? So you're going to have the sudden onset of a severe headache. That is your hallmark sign that this is a hemorrhagic stroke. Oh my gosh, my head hurts so bad. I've never had a headache this badly. And then the rapid decrease of their level of consciousness. That's going to happen too. So when it happens, it's especially like if it's in a healthy person, we call that a berry aneurysm. B-E-R-R-Y, berry aneurysm, like a raspberry or a strawberry, but just a berry, okay? And what it's kind of like is like a little bitty tiny balloon, and it just pops from the cerebral artery, okay? And I'm not going to get into the rest of that. You guys can continue to read, but remember about herniation. Remember, if we have enough pressure, the medulla oblongata is going to go down, and you're going to have some pretty nasty vital signs at that point, okay? So let's talk about intracranial pressure. Hemorrhagic strokes that cause bleeding into the brain put risk of the increased ICP. We've already talked about that. The brain is going to become ischemic, and then we're going to have that herniation through the foramen magnum. And within the cranial vault, you have all of this shifting that's going to happen. Okay. And when that happens, you have your brain, your blood, and cerebral spinal fluid that are going to shift. When that occurs, don't you think that the blood that's available to the brain is going to decrease? Yup, it sure is. And remember what happens when you decrease blood flow to the brain. You decrease oxygenation. So now we're ischemic, especially in that area. And then our cerebral perfusion pressure, and that's the pressure that's within the blood in the cranial vault, that's going to begin to fall. So it's all bad. Now, if the ICP rises sharply or blood pressure falls critically, your patient may experience life-threatening issues. So I'm going to go ahead and tell you what you can do in the outside of the hospital is not really going to help. But what are you going to do? We're going to do the best we can. Get him to the hospital, right? You guys can look at this. The first one's normal. We have an abnormal. You can see the brain shifting over. Blood volume increasing. So it looks like there's something organic there. And then there's the other abnormal where you have a herniation on the outside and it's moving the brain tissue forward. Okay, so TIA, we're going to move on into this one. This is a transient ischemic attack. Now, I'm going to go ahead and tell you, a TIA is the short term, people call it mini strokes. Okay. And I guess that's a good term for it. And it's mini stroke because everything resolves within 24 hours. It just goes away. Can you have multiple TIAs in one 24-hour period? You absolutely can, but the clock will reset on the very last one. Now, at the end of that, you're going to have people that if they don't change their lifestyle, medications, and a whole lot of other stuff, within 6 months, they're going to have a major stroke. And this time it's not going to be a TIA. It's not going to go away within 24 hours. So TIA is kind of the big hallmark warning symptom of, hey, you got to quit. Okay, I'm getting your attention now. We can be better, but you can't have that beautiful picture that's over there on the side of the screen because then this is going to happen again. Okay, so that's one of the things you got to change. So, but in the event of a TIA, you do have blood flow restored to that area of the brain. So whatever happens, whatever was affected during the TIA, that goes away. It's resolved within a 24-hour period. And so that's how we know. I have literally been in front of a patient before where we were going license hours to the hospital because I'm in the back of an ambulance. I don't have a CT scanner. They're having stroke-like symptoms or treating it like a stroke. We're going as fast as we can to the hospital. And by the time we got about 10 minutes away from the hospital, I was like, cut it off. My driver was like, what? And I actually had a driver. I did not have an EMT or an advance. It was a literal driver. Just cut it off. Just go normal. We're okay. Because of the TIA. It resolved right in front of me. It was pretty awesome to watch. But this is still an emergency. I just didn't have to go license sirens at this point because I realized there's something different going on here. So anyway, they still have to go to the hospital. They still have to get evaluated. They still have to change a lot of things about them, okay? So what are some signs and symptoms of a stroke? You have your facial droop, sudden weakness, numbness, tingling, decreased or absent movement and sensation on one side of the body is always going to be unilateral, ataxia, sudden vision loss, dysphagia, decreased level of responsiveness, sudden and severe headache, dizzy, weak, combative, restless, tongue deviation, coma. There's a whole slew of things, okay? And you just continue on. You guys can read your book on that. So left hemisphere problems. Left hemisphere, remember we talked about how the left is mostly about talking, about speech. So it may cause aphasia, okay? So that's one. Paralysis of the right side of the body. And then the right hemisphere problems. And by the way, aphasia is the inability to produce or understand speech. It's both. So it's not just being able to receive. We call that receptive aphasia. And then you have just aphasia, which is both, okay? Your right hemisphere can cause paralysis of the left side of the body, and words may be slurred or hard to understand, okay? And usually they can understand language and they're even able to speak, but their words are going to be slurred. So left hemisphere There are some strokes that I don't recall which one it is. And maybe Bethany knows, I'm not sure. Heck, anybody in this class could potentially know what it's called. But they, instead of being able to speak in a normal sentence like this, like, do you understand what I'm saying? They might say dog, cat, guitar, book, purple, water. But they think that they are answering your questions appropriately, but they're not, because the brain, that left side, the area, the Broca's area, is not working efficiently enough for them to understand, even though they think they're talking to you correctly. So if you do see that in the field, don't laugh it off and think, oh my gosh, what have you taken today, sir or ma'am? Sounds like a speech from stop. But it does. It's something that's a legitimate thing, okay? Now, if it's slurred speech and hard to understand, we call that dysarthria. Not necessarily word salad. Word salad is answering a question, but it's answering a question with a bunch of sentences that do make sense on their own. This particular one is not. It doesn't make any sense at all. It's literally random objects and nouns put together. And I think it's usually nouns that they put together. It doesn't make any sense at all. Patients may be oblivious to their problem, and those symptoms are called neglect. One of the things that you will see, and put a hand in the comments for me if you have seen the video of the dog attacking his foot. There's plenty of them out there. And a lot of people think it's hilarious because they don't know what's really going on. But put a hand in the comments if you've seen that, or a me or whatever. It doesn't have to be like an emoji. Just put something like, yeah, I've seen it, okay? Because I want to see. Visual fields being confused and lines crossed. I'm trying to, it has to do with visual fields being confused and lines are crossed. Yes, I think you're right about that. Yeah, because they don't really understand what's going on. Yes, yes.
All right,
Okay.
I was trying to help you out, and I'm trying not to interrupt you. So,
You're
as soon
fine.
as it's what I'll do is just for funsies. If I can get the correct name of that, I'll put it in the chat for everybody, just for contact.
Thank you so much, Bethany. It's just an interesting something that
It
I've
is.
run across in the field and did not know. I really was like, I didn't know what was wrong with this patient, did not have an idea in my head that this was a stroke. And I was definitely told by the ER physician that it was not a laughing matter. Yes, Mark, it's on TikTok, it's on Facebook, it's everywhere, where a dog is like growling at his arm and his leg, and he's like, and then he goes and he attacks it, or he sees his tail and he attacks it. There's multiple ones. And what that's called is neglect. They don't realize, and a human not necessarily will attack their own body, but I've witnessed this multiple times where, and it's always women, I've not seen a man do it, but I've seen a woman where her hand would start moving into her face and her field of vision, and she wasn't really moving it, but it was moving into her field of vision, and she would, stop touching me. And you think, what is wrong with you? They're having a stroke. They don't understand that this is their hand. They think it's someone else's, and they have thrown the hand. And so that's something that's called neglect. Now, patients, it is generally very difficult to detect all of this in the field, but just be aware that this is a possibility. It's not always some sort of a drug or alcohol issue, that these are stroke patients, and it's just not something that you've seen before. So I want to make sure that you are aware that these are very big issues out there that you are going to see potentially at some point in your stuff. Okay, Jared put something in the chat. I can't open that right now, but I appreciate it, Jared. We will get to it later. Neglect causes many patients delay seeking help because they don't know. They're unaware of the problem. And what can be happening is they could have bleeding in the brain. They could have, they may present with hypertension. Sometimes the hypertension is the cause of the bleeding, but sometimes it's just a response of vision vestibular dysfunction. I think that's exactly what it is. Thank you for that. Something very interesting. So what are we gonna do? We got to monitor our blood pressure. We got to monitor our heart rates. We got to worry about the increased blood flow and the increased pressure. So that's really important for us to know. Are we still gonna start an IV on this patient? You bet your bottom dollar we are. Advanced EMTs. We're absolutely gonna start an IV on this patient. Okay, conditions that may mimic a stroke. Okay, yes, that's one of them where the dog is trying to chew its own foot. It's because that dog is actually having a stroke. It's not just something funny, but people don't realize that because they don't think that that's something they need to go to the hospital for. So that's something very interesting to see. Receptive aphasia means that they can't understand what you're saying. So we're talking like this, but they're not getting it. And it's not one of those, huh, I didn't hear you. And I've only seen it one time, and it was complete and total confusion. The patient became extraordinarily anxious, and the only way to communicate was with hand signals. That was it. She did not understand a word that I was saying, and I understood what was going on at that point because she had the droop, she had everything else, and I was like, okay, she has receptive aphasia, she doesn't get it. And so those we have to be really careful with, okay? So good question. Okay, conditions that may mimic a stroke, you have hypoglycemia, you have your postictal state that you will have after a seizure, and you have subdural or epidural bleeding, okay? And the subdural bleeding and epidural bleeding usually occur because of a traumatic injury, so you will see those for the most part. And we'll go back and say hypoglycemia. And those patients not necessarily have they don't have like the paralysis and such like that, but they definitely have an altered mental status that can appear that way. And in some cases, some hypoglycemics can have a seizure and a postictal state, which is that portion after the seizure before they come all the way to, it may appear that they've had a stroke. Okay. And you guys can read up about the rest of that. We're going to go ahead and take a real quick 10-minute break before we get into seizures. And then we are going to finish this out and hopefully be done by 8 o'clock, okay? Or before 8 o'clock, okay, guys? So let me get my phone ready and you guys can go watch those videos.
A question, Patricia?
Do what now?
Can I just ask a question? Do you see me as in the class or as a guest? Because I hurried up and I signed on.
I have no idea.
Okay.
You're not as a guest. You're in.
Okay. Thank you, Jared.
Okay.
I believe that was Jared.
Yeah. I see you as B124. So yeah, you're
Okay.
in
All
as
right.
not a guest. Okay.
I just hurried up, came in the door, and just got on.
Okay, great. Thank y'all so much, guys. All right, I'm going to mute myself and turn off my camera after I get my timer ready, guys, and we will start our 10-minute break now. Okay, guys, let's go ahead and start with seizures. Okay, so it's a sudden erratic firing of neurons. So instead of it being like the absence of neurons going off, it's a whole bunch of them going off all at the same time, okay? And it can be from just having their finger is having a seizure, this is a real thing, to full body tonic-clonic seizures. So they're so huge. Some of them have metallic taste in their mouth. Some of them have an aura beforehand. And so they're all different. You guys can look at table 19-2 to check out the differentiations between these. But your tonic-clonic seizures are going to present with the greatest assessment challenges, just because the fact that when you have the seizure, it follows a pattern and it moves through in certain steps. And even though the patient may not really experience all of them, they may have an aura, which is a sensation before the seizure, and it may be like a small muscle twitch. They may see a light, a specific light. They may have a hearing associated with like a high-pitched noise. They could have that metallic taste in their mouth prior to. But if you have a loss of consciousness, then your tonic phase, hypertonic phase, clonic phase. And then you have the clonic phase is that rhythmic contraction of major muscle groups. So usually it starts with the arm, leg, head, and then you have lip smacking, biting, teeth clenching, and then you go to your post-seizure. This is when everything relaxes. And then you have nystagmus. And sometimes your eyes will roll back in their heads. Sometimes. Now we have our postictal phase, and this is just the reset of the brain. It's like the Control-Alt-Delete, okay? And this can take minutes to hours before they come back out of this phase. So if it's like a status epilepticus and they have been having a seizure for over an hour, it can take several hours for them to come out of a postictal phase. But during the time that they're in the postictal phase, they are often aphasic. They're confused, unable to follow commands. They can be extremely emotional and just cry. Some can be angry, tired, sleepy. They most likely have become incontinent during the seizure, but definitely during the postictal stage as well, because at that point, their muscles have completely relaxed and the incontinence takes place. And then they'll even have a headache too. But you also have something called pseudo seizures. Now, this is a generalized neurological event, and you may not notice any difference from a tonic-clonic seizure. And the root cause is psychiatric in origin. The patient may not intentionally be causing this behavior. Now, I'm going to pump our brakes for about 5 seconds here and talk, especially the people that are in the advanced EMT class. You guys have already seen a lot of people that are out there in the field, and there's one thing that we all do. Okay, I'm guilty of this. I know everyone in the class is probably guilty of this, of, oh my gosh, you're just faking a seizure and rolling your eyes. However, I do want to impress upon you this one thing. When you do have, and this is in some cases, where it is a true pseudo seizure, I want you to think about this. There is a condition out there where a woman wants to become pregnant so badly that they will literally lactate without being pregnant, without having any children prior to. There's zero reason for them to be lactating, but it is a psychogenic thing. So when we say that the mind is a very powerful thing, this is part of that, okay? So these people have a psychogenic issue, and because of that, they will have seizures, but they're pseudo seizures, okay? But this is a motion that occurs during the seizure, is relatively organized. Then you have absent seizures. That's little to no movement. As a matter of fact, absent seizures is something that a lot of children have. They grow out of it as time goes on. But if you ever have children, and by the way, everyone in this class has had this, because what I'm about to describe to you is, have you ever watched children on a playground or been around a lot of kids and they just stop and they stare? Their whole body just stops. It's kind of like a glitch in the mainframe, right? It's not. It's an absent seizure. Lasts between 1 to 3 minutes, then they're fine. It's never really a big deal. They grow out of it. I'm not going to sit here and tell you that when you stare off into space that that's an absent seizure, although in all likelihood it's really close to it. When people stare off into space, though, sometimes they can still move their hands and their arms, their feet, their legs, all of these different things. So staring off into space is a neurological condition. I don't know what it exactly is. I have heard some neurobiologists state that it is a type of absent seizure. I've heard actual neurologists say you're just staring off into space and there's nothing wrong with that, because I'm generally curious and I ask a lot of questions. So with that being said, do your own research on that one, but the absent seizure is not something that's going to be a bad thing. So there's no postictal phase, there's no confusion, none of that. But it may be brought on by flashing lights. It can be brought on by hyperventilation. So if you see kids playing and suddenly they just stop in mid-stride and they just stand there, that's an absent seizure, okay? All right, simple partial seizures involve movement or sensation of one part of the body when originating in the frontal lobe. Do we still transport them to the hospital? You transport everybody that calls 911. Not gonna lie. There's a reason 911 was called. There's a reason that you're supposed to be there, and there's a reason you're supposed to help. Unless the patient themselves tell you no, then don't. Is there, you know, I can't tell you if a kid that has an absence seizure is going to get called for a 911. I don't think they will. I've never heard of it. Does that mean that it's never happened? No. Does it mean that it won't happen to you? No. But if someone calls 911 because they see that there's something abnormal going on with their child, I'm absolutely going to take them to the hospital. Just end the discussion. Just because I'm always going to err on the side of caution with all of my patients. Even if I am not experiencing their pain, I'm not going to do it. Okay. Can I tell you that if my level of pain is like at a 6, I'm not going to be doing this. Okay. I'm not gonna be on my phone. That's just me. But there are people that are in labor, obviously 10 out of 10 pain, because we all know labor is the most intensive pain you can have. And they're over here like, oh, I just gotta get some last takes out. I'm done. We call those ladies Superwoman or lots of things. I can't do it. See, ow, I don't do pain. Okay, anyway, that went off on a tangent in a whole different direction. But if I call 911, rest assured I want to go to the hospital. You know what I mean? I don't want to be checked out. Okay, involves all patients go unless they are GCS of 1580 times 4 and a refused transport. That's exactly right, Lindsay, 100%. And they have to refuse the transport, and they have to be GCS of 15 with 80 times 4, 100%. Okay. Let me get back to where I was. Partial seizures. Okay, so it's going to be one part of the body, and then they may stay in one part of the body, but it could spread to others, and it'll be in a wave. You'll see it. Then you have your complex partial seizure, and that's going to be like a subtle change in your LOC. They're going to become like a little confused. They might lose alertness. They may even have some hallucinations and even be unable to speak, but their eyes or their head may make small movements, and it's almost like a tic. Patient usually doesn't become completely unresponsive. Seizures lasting more than 4 or 5 minutes. Status epilepticus, I missed one. Status epilepticus is the big one. Now, these are seizures lasting more than 4 or 5 minutes. The time frame is really arbitrary because some authors suggest that the status epilepticus does not occur until 30 minutes or of uninterrupted seizure activity. So it depends on where you read this, if you will, okay? Refer to your local protocols for guidelines on how long a seizure can continue before you should intervene. I see someone's hand up. Deborah, go ahead and put it in the chat for us since you are, you're in and capable of putting it in the chat, whatever your questions are. So you're going to refer to your local protocol and guidelines on this one, on how long a seizure can continue before you should intervene. So think about this. One of the biggest things that we have to think about with a seizure, especially with a whole full body tonic-clonic seizure, the body is moving at such a crazy pace. And let's say that this patient has had one for 30 minutes. What happens is the neurons are in this hyper-metabolic state. So for a short time period, there's no real prolonged long-term damage, okay? But if this seizure does continue, the body cannot remove those waste products effectively. So think about when you're running and your quadriceps get really sore because they're burning, right? Well, that's called lactic acid buildup, actually. And so unless you stop and allow more oxygenation to get to those muscles, they're going to continue to burn. Well, it's the same thing with a seizure, but they can't stop that. So they have a lot of lactic acid buildup, but on the other side of that, they also lose glucose because it's like they've run a marathon within 5 minutes to 30 minutes. So their bodies are depleted of a lot of glucose. So you guys are going to also check glucose after these seizures are over because you want to make sure that you're not just stopping the seizure, but you're also making sure that the patient is going to be okay. Because sometimes when you get to these status epilepticus patients, when you've got the opportunity to stop the seizure, and this is when you're going to call for ALS backup because you guys can't do anything about that. Advanced EMTs are going to start an IV, absolutely, but you can't give that type of medication. So what are we going to do? Start that IV and we're going to check a glucose, okay? what happens when the hand starts to jerk inward? Well, that one's going to be that partial. That's what we were talking about earlier. And that's defined. Let me make sure. It's going to involve just the movement and the sensation of one part of the body and originating in the frontal lobe, or it could be in the parietal lobe where it starts, but it's usually just one part of the body. And you can see all the common causes. Okay, that's going to be a partial seizure then, Deborah. That's most likely what's going to happen. Because they don't become unconscious with partial seizures mostly. Mostly they don't. Okay. Oh, you're welcome. Okay, so 19-3, common causes of seizures. There are so many different reasons. You guys can go ahead and read all about these. High fever is one. Okay, febrile seizure. They can, and that's going to be mostly in your infants and small children because their temperature regulation has not been fully developed in the brain yet. And that's why children can have a seizure because their temperature gets to 104 very quickly. But firemen go into burning buildings and it's well over that temperature, and their body temperatures do get within excess of 104-degree temperature, and they don't have febrile seizures. It's because your brain is developed, okay? So you guys can read about those. It's important to recognize your seizures. Recognition when a seizure is occurring has occurred, and whether this episode differs from previous ones. So you need to ask if there's any bystanders, what's going on? Is this normal? Also understand when we're in a postictal state and the complications of those seizures. Remember, we're thinking about our airway at this point. We're thinking about the fact of their glucose level. We're also thinking about the fact that when they wake up, they don't know who you are, and you are a stranger. Okay, so it is not uncommon for someone in a postictal state to come out of it and be threatened because they don't know who you are. So keep that in mind, and look for other problems that may be associated. So once the patient's seizure has completely stopped, we go into what's called a postictal phase, and that's where the muscles become relaxed and they become flaccid. It may be characterized by hemiparesis, or weakness on one side of the body, also resembling a stroke. Remember, we talked about that earlier. And it's most characterized by the lethargy and confusion that a patient may have, and I already talked about the combativeness. So, altered mentation or altered mental status. This is literally anyone who's not ANO times 4 and alert, okay? So they may be all the way to unresponsive to just a little confused. So causes are numerous, okay? I'm not even going to read all of that. Numerous. Hypoxia, remember I told you they become anxious. That's the first thing. Unrecognized head injury. You guys can read about the rest of that, okay? So literally anything in this world can cause an altered mental status. You just have to be a good enough detective on scene to kind of figure out what it is. Syncope, fainting. That's all it is. Syncope. Syncope is fainting, okay? Sudden and temporary loss of consciousness with accompanying loss of postural tone. So what does that mean? They literally just go frump, and they just frump. I am a sound effects person. I can't help it. I hang out with a lot of dudes, okay, from the fire service. So sound effects are a thing. But you drop like a load of nothing and you just fall down, and your whole, it's not one of these like, that's not syncope, okay? The body yeah, exactly. The body goes completely limp. Oh, I find it's best to talk to them the whole time when they are coming out of the station. Yes, Joshua, let's go back to what Joshua said. That's absolutely right. Pardon me. When you're dealing with seizure patients, you do want to talk to them excessively. And I roll my eyes because you want to tell them, okay, I'm here. We're coming out of the seizure. I just want you to know my name is Patricia. I'm starting this IV on you, or I've already started an IV on you, and I've wrapped your arm up really well because we don't want that IV going anywhere. And I just want you to know that I'm holding your hand right now and I'm helping you. And I'm talking to this patient like they're blind. And he's absolutely right. That is something that can help them because they'll hear your voice and they'll understand, especially if you're not yelling or anything else, if you keep that tone low and in a nurturing way. So great thing to say, Joshua. Thank you. Exactly, Deborah, the body just goes limp. Done fell out is definitely one of them. And yeah, well, I mean, they're going to go unconscious. That's the only, that's the whole point of it. They go unconscious in this particular instance. So what do we do for that? Well, we figure out what the main reason is why they did it. Did they have a cardiac rhythm change? Did they have a conduction issue with their cardiac rhythm? Is there a problem with the cardiac muscle? Because remember, the brain does not operate without blood flow, right? So has there been an interruption because of that? Is there an MI? Are we dehydrated? Is it hypoglycemia? Did they vagal down? Vasovagal episode. And if you don't know what that is, it is where you innervate the vagus nerve that runs all the way through from, it's innervated through the diaphragm, and it goes all the way down to the anus. And so I know some of you guys are probably at home laughing when I say this, but I want you to understand that there's something called vagaling down. If you bear down too hard when you are trying to have a bowel movement and you pass out, that is called a vasovagal reaction. So a vasovagal episode even. And it's where the vagus nerve that is responsible for your heart rate, when you innervate it, when you mess around with it, your heart rate is going to go really, really low. And what happens when your heart rate goes really, really low? Well, your brain stops getting blood. If your brain stops getting blood, you stop getting oxygen. So guess what? Don't bear down that hard when you're going to the restroom, okay? And I don't mean for that to sound funny, but it is kind of hard to explain that in some cases. But it does happen. So if you've ever, and definitely you have to eat more fiber, guys. Like that's a big deal. And you're not going to get that from that picture above that Jared supplied us with earlier. Okay. You're not getting fiber from Mickey D's. But you guys, it's so important for you to understand that these people, that they will vagal down and they'll pass out and then they'll come right back. Okay. So moving on. Headaches, you have your tension headache. Okay, Lindsay says stress and psychiatric issues can cause syncope too. POTS, yes. POTS is a big one. Can absolutely cause it. Jared, done with you. Mark, don't. I already know Mark's about to. Well, Joshua, I think Taco Bell and Crystal don't count. Maybe. Okay. Tension headaches. So caused by muscle contractions in the head and the neck and are attributed to stress. So when you have these tension headaches, you're going to feel it in the back of the neck first, and it's going to go into the base of the skull because you're going to feel that. It's going to be the muscle contractions causing that headache. You have migraines. Guys, migraines are thought to be caused by the increase in blood vessel size at the base of the brain. Let me tell you something. I have migraines that last for 3 days. It's not a joke. They always come on at night. It's ridiculous. It's horrible. It's the worst thing in the world. Okay. And there are people that have migraines that eventually they will have seizures with. So there's a lot. And they may have an aura. I have an aura with my migraines. And I start seeing sunspots and they'll go across my vision until it gets to this side. And then I have a migraine. So I know that it's coming. And sometimes if I take my medication fast enough, I'm okay. But I have to do it for 3 days in a row. It doesn't stop for 3 days. For 72 hours, I have this migraine. So, okay, thanks, Mark. We will go over POTS later, but right now that's going to be a 20-minute lecture. Look it up. I can't remember exactly what it's called, but it's a whole bunch of different issues all at one time affecting females. So it's hard to get a diagnosis for POTS. Even though a lot of women have it and have been undiagnosed for years. But we'll talk about it later on. Oh, thank you, Bethany. Postural orthostatic hypotension. There you go. But it's not pretty. Cluster headaches. I got you. Thank you, Sierra. Okay, so let's talk about cluster headaches real quick. That's going to be a rare vascular headache that occurs in groups. And it is rare. Somebody tells you they have cluster headaches, they have to be diagnosed by a physician because it is one of those rare ones. It's a minor pain, but it just intensifies. They get anxiety and all sorts of stuff along with it. Sinus headache, never mind, I know, brain fart. Okay, you're fine. You're absolutely fine. Always ask questions. Sinus headaches are the inflammation or an infection within the sinus cavities of the face. So I will say this, when I was growing up, and for years and years and years, and I don't know why I did not realize this, but when I always thought of a sinus headache, I always thought, oh, it's sinuses from hay fever or pollen or whatever. Well, yes, because that causes inflammation in the sinus cavities that we have in our skull. So if you look at a skull, you'll see that you have these sinus cavities, and they become inflamed, especially around times when you have pollen and such. But if you have a sinus infection in the cavities inside the skull, it can cause a sinus headache also. So it doesn't have to be the only time you have a sinus headache is in the springtime, is what I'm getting at. Because I looked at someone like they were crazy when I was in paramedical. I was like, it's winter. How do you have a sinus headache? And they're like, I have a sinus infection. I was like, but there's no pollen. And so I always try to make sure that y'all don't learn from my ridiculous mistakes. So anyway, okay, patient assessment. We're going to get through this and we're going to be done. So remember, when we're talking about the brain, there could be fluctuation in oxygen levels and glucose. We always want to make sure that we check those and identify what is going on with the patient. Scene size up, is it safe? Is it not safe? Take standard precautions. What is my MOI? What is the history? Where's our stroke centers? Where are our neurological centers in this? Is it quicker for me to go by air, or is it quicker for me to go by ground? We're going to look at decorticate and decerebrate. Core to the core with the arms, if you can look at that, core, and decerebrate is out. Decerebrate is worse. Okay, and that's going to be abnormal posturing. We're going to worry about our ABCs first. Remember, we can't look at our airway and understand if our airway is patent, or we can't look at breathing unless our airway is patent. So in some cases, we have to make that airway patent with whatever we have to do. Remember to provide ventilatory support when necessary at 10 to 12 times per minute with breathing. Remember, if your patient is apneic or unresponsive, then you're going to go ahead and start those chest compressions, right? Stroke patients, they can have difficulty swallowing, so they may choke on that, so be ready for your suction. So circulation, vital signs, of course, and we're going to check those as we go. Transport decision, of course, if they're unstable, that's going to be our priority patient. End of discussion. And we're going to focus on stabilizing just our ABCs. And as you can see here, this patient is put into the recovery position on the stretcher. Is that something that you can do? Absolutely. And as you can see, they've put a pillow in between the legs for just in case this patient has another seizure. So that's something that you won't see unless you see it. Like, there are people that don't do that. That's one thing. Why? Because it stops excess injuries when they're going down the road. Okay, history taking, huge. Okay, definitely get their history. If they are, if they have ultramentation, check to see if you can find medications, check their phones, check for bystanders, check family, whole 9 yards. Get as much information as you can about this patient. Is this seizure different than the last? Have they had a stroke before? Did they have a TIA in the past? Asking all of these different things. Evaluate your patient's speech. Look for obvious trauma and gather your sample history. Now remember, when we're also doing our assessments, and I think I'm getting ahead of myself. I'm going to stop for a second. Remember, secondary assessment as soon as possible, because we want to look for, we want to see where we're at with things, right? So we're going to look for potential causes of our neurological signs and deficits and symptoms and everything else. Assessing for injuries, rapid ID of a stroke is imperative. At this point, before you even get to your secondary assessment, you should know if this is a stroke or not, and you should already be in the back of the truck going. And use your common stroke assessment tools. Now, this is what I was talking about. Like, I knew it was coming. So you're going to perform at least 3 physical tests on these patients if we think that they are experiencing or have experienced a stroke. We're going to test their speech, facial movement, and arm movement. And if any of the three is positive, which is abnormal, okay, then you're just going to go ahead and assume that this patient is experiencing or has had a stroke. Now, this is the basic of basis, okay? So test of speech is have the patient repeat after you. Can't teach an old dog new tricks. Okay, so what that does, that particular sentence carries over for all the cranial nerves that can be innervated with the pattern of speech. You may hear someone say, stick out your tongue. You may see other people say, smile. That's your facial movement, okay? And then arm movement is simply, okay, ma'am, sir, I'm going to hold your hands out right here. Then I'm going to let go, but I want you to close your eyes first. So you close your eyes, and if they drop one of the arms, then that means that they have the other side is the affected side, okay? Another one is Cincinnati Pre-Hospital Stroke Scale. That's going to be on your table 19-5. You have your LA pre-hospital stroke screen, which is table 19-6. VAN positive. I didn't see VAN positive. I didn't even read VAN positive. Define what you're talking about. There is a checklist in table 19-7 that's going to help you with all of fibrolinics. Large vessel. Bethany, I guess I missed that. VAN stroke assessment.
I think that's a Louisiana thing, possibly.
Okay.
Unless it's like not a Mississippi thing or something. Some states don't recognize the VAN assessment. VAN is for your visual disturbances. A is for your aphasia. And it's for neglect, and it's to detect a large vessel occlusion. It's just a faster way to determine which facility the patient's going to go to. I think it's only a Louisiana thing, if I'm correct. Could be wrong, but
my husband is in the next room and just screamed all of that to me, and I'm like, oh, I had no idea. Like, he's opening the door right now to tell me.
So yeah.
Oh, okay. He's saying that it's Louisiana based only, and it's because he's a medic in Belle Chase in New Orleans.
Yeah.
Yeah.
We're special over here. It's okay.
Yeah, and so he runs all those calls up in there, and he helps with Plaquemines Parish and all that. So he was talking about how it just means that, like, if you think that that's a complete obstruction or occlusion, you have to go to a specific one. So thanks for that, guys. I didn't realize it. So I appreciate you guys even bringing my attention to it and answering the question too. That's awesome. Thank you. Hey, we did. We all learned something today. Good. Okay. Remember, we were going to talk about, or we're going to check our GCS. And remember, that's on table 19-8, blood pressure. We got to check that a lot. Frequently assess, continue to assess that blood pressure, but also your ABCs, and see if there's any changes in pupil size and reactivity. I'm an EMS administrator and volunteer Belle Chase firefighter as well. Oh, really? It's Doty. It's his last name. So you may know him. I don't know. During most active seizures, it's imperative to evaluate vital signs. I've said this before. I will say this again, because if your blood pressure is going up, you guys, then that means that you can be having increase in intracranial pressure, and we don't want that, right? So we want to check our pulse, rhythm, respiratory rate, depth and quality, our skin color, temperature and condition, pupillary size and reactivity. We want our blood glucose levels to be compatible. We'll talk about it later, Deborah. Let's get to this first. Let's get through this. Determine the pulse ox. And remember, if it's a higher ETCO2 level, then that's going to indicate that's inadequate ventilation. Yes, that is exactly what he was saying, Lindsay, was that it means that if you have, if the VAN assessment has any positives to it, then that means that they're going to go to a comprehensive stroke center. So very good. Remember, we're reassessing everything that we've done beforehand, which means that we're reassessing our ABCs, our vital signs, and all of our interventions. And you know what? You guys can have casual conversation to check to make sure that their brain is still functioning appropriately, or if there's something else. Pardon me. Bethany, thank you so much for that. And she's saying that there are multiple tiers of stroke centers. Here in Mississippi, we don't really have that. We have We have 3 different ones that are in the centralized area that are all stroke certified. So we just, pick one of the 3. They're all within 5 miles of each other. That's really not a joke. Yeah, West Jeff is our stroke center. Yeah, he goes to West Jeff a lot. Okay. So remember, we're going to continue to reassess all of those. Always provide our emotional support when we're talking to these patients. Do not ever tell a patient that they're going to be fine, because first off, that's a lie. We don't know. We can't tell the future. And if you can, I need to talk to you after class. We're going to go run and do some lottery tickets. Okay. But unless you can do that, don't tell a patient that they're going to be okay and everything's going to be fine. Just don't lie to them. Okay. Document all your findings and make sure that you start with what stroke scale you used. Make sure you talk about the GCS and the reassessment of all of those as you go. Make sure that if you have any changes throughout, that you put that down on a reassessment as well, and document literally everything. You can't over document enough. I'm not going to lie about that. Okay. So if you've done an intervention and it didn't work out, then you document it didn't work out. Okay. So guys, you advanced EMTs, you start an IV and it doesn't work. You make sure that you put down, hey, it infiltrated, and what you did to stop the bleeding and to stop any unnecessary risks of infection that may be occurring. Okay. So for patients who experience a seizure, give a description of that seizure activity. Document the onset time and duration, and record any interventions performed during. So home stretch, guys, almost done. We're gonna get out of here by 8. Okay. All right, so emergency medical care, just generalization. Anyone that has some sort of a neurological issue, our best treatment is determined by performing a thorough assessment and maintaining our ABCs, okay? There's really not a whole lot you can do for a stroke, right? There's really not a whole lot you can do for a seizure. But now we can do some stuff for hypoglycemia, and we definitely can do something for hypoxia, right? So what are those? It's all ABCs, okay? It's all making sure that we have performed those to our utmost. Remember that medications available for our pre-hospital treatment for our hypoglycemia is dextrose and glucagon, and glucagon is a shot. Now hypoglycemia is definitely more lethal than hyperglycemia. Yeah, the brain may go into a coma during hyperglycemic events. But when your brain goes into a coma because of a hypoglycemic event, it's because the brain is dying. Remember, we have to have 2 things to survive with our brain, right? Oxygen and glucose. So if you don't have any glucose, brain's dead, okay? So ensure your IV is patent before you give or administer D50, because if it gets outside of the veins, then it's necrotic, can cause necrotic tissue. I have a little caveat to share before we leave, all related to the GCS, stroke scale, etc. Absolutely. That would be great. Thank you, Bethany. Hypoglycemia. No, I already said that. Okay. If you cannot get vascular access, advanced EMTs administer 0.5 to 1 milligram of glucagon subcutaneously or IM. And if your blood glucose does remain low, repeat the glucagon shot for a maximum of up to 3 doses. Oral glucose can be given to anyone with a decreased LOC who can protect their own airway. We're going to ensure that they don't aspirate. That's really bad, right? Be calm when dealing with these patients and reassure that you're there to help. Stroke, just assume the patient with a TIA or stroke symptoms is experiencing a full-on stroke. Give them oxygen. Now I'm going to go ahead and go back here and say, remember the 94, SPO of 94. If they're at SPO of 94, unless they're having trouble breathing, never withhold oxygen. But if they're at 94%, on SPO2, they're okay. All right. I have plenty of experience with hypoglycemic events. My grandma has sugar as low as 30 sometimes, so we have called EMS for her a bunch. Yes, and it's something that just happens. So I'm glad that you do have a lot of experience there, and at least or you're able to see what happens and how to kind of help gauge. Okay. Unless you're concerned about possible spinal injury, just elevate the patient's head 30 degrees, ensure the airway is clear, obviously, and watch for your seizures. I can't read that because it's really small on my screen, but I know you guys can find the adult suspected stroke algorithm from the AHA and use that, okay? TIA, standard care, same management guidelines for a stroke, continue with your neurological assessment, strongly encourage your patient to be transported, because we know that if it's a TIA, within 6 months, we're going to have a pretty big problem if you don't change some stuff. Seizures, patients require a definitive evaluation and treatment at the hospital. Go ahead and give them O2, suction if necessary. Always watch for that. If watch their airway, make sure they don't aspirate, and provide positive pressure ventilations as necessary and transport. IV access for our advanced EMTs naturally, and depending on local protocol, you should assess and treat the patient for possible hypoglycemia. So remember that. Many diabetic patients nowadays have continuous glucose monitoring. Yep, either the Dexcom or Libra, and they are amazing. I use Dexcom as a hypoglycemic patient. Wow. Okay, good to know. Thank you, Lindsay. I may end up emailing you asking you for more information just for my own curiosity as a medical professional. So if you're willing to share some information through email, I would love to hear it. Headaches, guys, thank you so much. Headaches, guys, we just have to be cautious with headaches because it could be something even worse than what we see. So once again, standard care, ABCs, medications, think about all of those. And you know what? It does say many patients will appreciate a darkened or quiet environment, so do not use lights or sirens while transporting. I'm going to go ahead and tell you, if I'm having a migraine and I'm calling for an ambulance, you are not using those lights in the back of the truck, or I will just, you know, be a Karen, because that's wrong. I have gone to the back of an ambulance one time with my sunglasses on, okay, because I thought I was having a stroke because it was so bad. Okay, I'm going to go ahead and stop sharing, and I know Bethany wants to unmute, so just hold on just a second, guys. Let me stop sharing and also stop recording. Uh-oh, if I can find my stop recording.